Check.
Participants, kindly mute your audio and video. Many of you have kept your videos on. Can you please switch off your videos? And please do not press present now option.
Hari, hello. Hari?
Yes, ma'am. Ma'am,
Yeah, we can
start.
Can we start? Can we
Yes,
start?
yes.
Okay. Good evening, one and all. On behalf of the Department of Speech, Hearing and Communication, NIEPMD, it is my immense pleasure to invite you all, academicians, researchers, teachers, heads of the institutes, professionals, students and parents from all over the world to attend the international Webisode on autism spectrum disorders, the Spectrum of Needs, Series 2, organized by the Department of Speech Hearing Communication on September 6, 2020, NIEPMD Chennai, Tamil Nadu, India. It is my pleasure and honor to thank Shri Nachiketa Rawat, Sir, Officiating Director, NIEPMD, Government of India, Chennai, for his permission and approval to conduct the series of episodes on ASD. Due to unavoidable reason, Sir could not join the episode today. So we are moving on to hello, welcome address.
Hari,
as the organizer of the international
episode,
can we start? On ASD, I'm honored and pleased to welcome. Good evening, one and all. Dr. Amarnath sir, on behalf of the Department of Speech Hearing Communication, it is my immense pleasure to invite you for the second episode. It is my duty to introduce about Dr. Amarnath sir. On his capacity, he presented many research articles, publications, books in the reputed journals, and he is a keynote speaker. He addressed and coordinated many international conferences and RCI programs on empowering persons with multiple disabilities. And he is the king from 2005 onwards at NIEPMD and established the institute from the old to now. And he is an academician and administrator in the capacity of in charge deputy registrar of NIEPMD. I welcome you, sir, for the inaugural address. Over to you, sir.
Thank you, Kala.
Yes, sir.
Welcome you all for the second series of this international conference on autism. That episode will be very helpful for people. I hope many of them joined and they're showing interest. Many of them who attended the first series must have got a lot of important points from you, and it might be very useful. I really pleased by giving this welcome note address on this important program. Especially, I am very thankful for the speakers, especially that Dr. Sapna Bhatt Madam, who had given the first series very important topics she shared with us, and this time also she is sharing with that the social competency and communication skills of the children with autism, and other speakers like Gayatri and our department staff, Gayatri and Hari, and especially the program organizer, Dr. Kala, and Mr. Dhanavendan of Special Education Department. It's a good that we are not only concentrating the include the special education aspects, which covers the entire, at least maximum aspect of the autism spectrum requirements. So it's a very good thing that special education and speech and hearing department working together and doing this program, because that interdisciplinary collaboration is very much needed for us this time to address all the requirements of and needs of the persons with autism. So I welcome all the speakers and all the participants. Have a wonderful time. I believe that it's going to be a very useful time for you, which you are attending. So I wish you all the best. Go ahead with your episode. Thank you, ma'am.
Yes, sir. Thank you, sir. Thank you for your valuable and informative welcome address. Thank you, sir, once again. Moving on to the program. Allow me to warmly welcome Dr. Sapna Bhatt, speech language pathologist of Copenhagen International School from Denmark. I also wish to give a special thanks to Dr. Sapna Bhatt, highly knowledgeable in the field of speech and hearing. I thank her for accepting our invitation to share knowledge and experience about ASD. She has wide experience in handling children with ASD, both special and inclusive education. Dr. Sapna Bhatt has a PhD in speech and hearing, where she worked on investigating language mixing in bilingual aphasia. She has worked as a professor, researcher, and clinician in India and in Denmark for past 20 years. She is currently working as a SLP in Copenhagen International School inclusive international multilingual school, where she works with children who have variety of speech and language disorders like misarticulation, LLD, ASD, Down syndrome, etc. She is trained in various Hanen programs, social thinking, collaborative proactive solutions, and Linda Mood Bell Talkies program. Today, she will be talking about social competencies in children with ASD, assessment and treatment, where we will be learning about various strategies that can be implemented with children with autism spectrum disorder with a special focus on social competencies. Hanen-based and social thinking based methods will be specially talked about with the case examples and practical ideas for classroom usage and inclusion. Over to you, madam. Hello.
I'm
Yes.
coming on.
Yeah. Yes.
Yeah. I'm just getting ready to present.
Okay.
Right. So good morning, everybody. Thank you for some of you, and thank you to NIEPMD for organizing this and giving me this opportunity. Thank you, Dr. Amarnath, for your kind words, and Dr. Kala for your words. It feels fancy to call you Dr. Kala, so I'll say Kala because she's been my classmate, and I'm really, really excited to do this today. So before I start, in the message section, I'm going to share the link to my Google presentation, and you guys can just, look at it, or I'm just going to present my screen so you can also look at that. But I just shared the link in the comment section, so if anybody wants to look at the Google slides, you can do that. All right, so let's get started. I'm going to be talking today about social competencies in children with ASD. And there is a specific competencies and not social skills. Can you all see the slides? Can you all see the slides?
Yes, madam. Yes, madam. Yes, madam.
Okay. All right. Okay. So I would like to start with saying that we have to be very careful about what we mean by social. Now, I know that a lot of us are very used to hearing words like social skills, but I would want to make a little distinction here in terms of social versus social competencies. So before going into the description, I'll give you an example. I meet a lot of kids whose social skills goal is to help them make an eye contact. So we say, oh, we are going to help this child make an eye contact. And then I see these kids who are trying to look at me, trying to make an eye contact, but they look like above my head. So they're looking at me, but they're looking in a way where they're not even seeing my face. They're looking in my direction. So they are actually giving me an eye contact, but they are missing all the important information. So that's something like a social skill where we have trained these children to just look at you. Versus when we talk about social competencies, we might rather say something like thinking with your eyes, where we teach children that eyes give you a lot of information. So when you look at somebody, you're thinking with your eyes and you're getting a lot of information from people. You are looking at their facial expressions, their body language, you're looking at what's happening around you. So all of that is giving you a lot of information. So see the distinction versus social skills, where you want someone to just keep looking at you versus telling them thinking with your eyes gives you all kinds of information, and they understand that eyes provide you a lot of information about your environment, help you figure out what to do in a social situation. So if you're just teaching eye contact, it's a behavioral skill. You just want them to do a particular behavior. But on the other hand, if you're teaching thinking with your eyes, what you're actually doing is you are helping children understand, and you're building up cognitive skills for the children to be able to understand what's happening in their environment. So social competencies are a variety of skills that are required for people to function in a group, but not just function in a group. Also, when you are reading, for example. So if you're reading a text where it says the person stamped his foot and slammed the door and went out of the room. Now, you need to have social understanding like that, because you have to know that if someone is stomping their feet and walking out and slamming a door, that means that the person is angry. So you need social thinking, you need social competencies, not just to be in a group, not just to play with friends, not just to interact with your teachers, but you need social skills also to understand what you're reading or what you are writing. You need to understand how a reader is going to understand your story. So that's also social competency. So it's a very, very broad area where you are thinking about other people's thoughts, feelings, intentions. When you're walking around with people, you don't have to know people. But when you're walking on the road, how do you give space to each other? How do you not bump into another person? You need social understanding for that. Then you need social understanding for reading, for writing. You need social understanding, for example, right here. When we are here together and we are doing this group meet, we don't know each other, but there are certain things that we have to follow. For example, just to remind you, switch off your mics and switch off your videos. Just listen. That is what your responsibility as a part of the group is. So you have to understand that we can function as a group only if we stick to these guidelines. When you write an email, you have to think about what the other person is going to understand. So all these set of ideas are social competencies. So you can see it's not very limited to social skills, as we say, like how we would write in our lesson plans. We would say building social skills. But social competencies is much bigger idea than just social skills. We're not just talking about being able to do a particular thing. We're talking about building the understanding behind how you exist in a group. How you, for example, when you go in an elevator, right? You go in an elevator, you are with a stranger, you're not going to be picking your nose or doing strange things or, going very close to them. You won't do those things. Even though you don't know that person, there is a certain etiquette, certain manners that you follow when you are in an elevator. And these all whole range of skills, from how do you play with someone to how do you interact with a stranger to how do you read something, they are all called as social competencies. Or there's a specific terminology used by Michelle Garcia Winner, who is a founder of a program called Social Thinking. She calls it social thinking. Now, it's really important to understand this is not my terminology. I'm just presenting this information from Social Thinking program to you. Now, this social thinking skill or something by itself, it involves a variety of overlapping ideas, especially with language development, because social skills have a lot to do with language development. So because when you're talking emotions and feelings and what's happening, you are always talking, it helps you understand social, don't have a lot of skills. But we can use this approach for children who have average to above average language skills. And we'll come to that in a little bit. Next, I have, I know that our topic is going into assessments and treatments. I want to social situation, what are basic skills? And so that's why I have taken up this building blocks of social development for young children. As you can see on the slide on one side, the pictures. Again, I want to make sure this is not something I have compiled. This comes from Social Thinking program, but this is a very descriptive way of talking in order to be able to function well in a society. So if we can look at the building blocks, the first one is joint attention. So I'll briefly tell you examples of each of these and what they mean and how they connect with the social competencies. And then based on that, you have to start understanding that you have to develop your own skills to observe and assess this. There are so many test instruments there. You might be doing some language testing, you might be doing some observations, but the best way to assess social skills in the children is go out and observe them, go to their classrooms, go see them playing with their friends, with their brothers, sisters, see how they're hanging out with people. And for me, the most precious information I get about a child is in the school playground. There's no better place than that. All right. So, when you're doing an assessment, it is important for us to understand that assessment is not a task which is standalone by itself. So you've done assessment, it has no connection to anything else. No, that's not right. Assessment has to come out, has to give you information about what you're going to do in treatment, what you're going to do in therapy. So make sure that your assessment has all the information. All right. So your assessment should give you clear goals. Your assessment should help you figure out what do you exactly want to do with that child. All right. I remember, when I was a student, we used to assess kids, and then no matter what the kid did, no matter what the child's level was, we would say the recommendations are speech therapy, counseling, follow-up. That's terribly wrong. You cannot have the same 3 guidelines for everybody, no matter who that is. So your recommendation should be like, oh, we need to work on this skill. We need to work on play skill. We need to work on language, this particular aspect. We need to involve parents, so your recommendations have to be clear cut and they have to be individualistic. What you do with one child is not going to work with another child. And that's what your assessment should show you. So, coming back to the diagram here, coming back to the picture here and the building blocks, first one is joint attention. Joint attention is when 2 people or more people in a particular social situation are paying attention to the same thing. For example, right now we're not even together, but we are all paying attention to building blocks of social development. So we are focusing our attention on my slide and you're listening to me. In a classroom, the 2 children who intend to play together will have to focus their attention on the same toy. And we know joint attention is very difficult in children with autism. If some of you attended the previous webisode, you would see that when we looked at those videos where they talked about children trying to make connections with other people around them, we especially saw that children with autism find it difficult. So if you're pointing with your finger to a child with autism and you show them a toy, they might actually look at your finger, not at the toy. So they don't have the joint attention to look at the same thing as you. Because this is very important, because if you're focusing your attention on the same thing, you're going to be talking about the same thing later on. Then you're going to be playing with the same thing. So it's a very important basic skill. Then joint intention is just a build up from joint attention. You're focusing your attention on the same thing, and then you intend to do something with that. So you're focusing, 2 children are focusing their attention on a toy, and now they want to play with the toy. Next is imitation. Another important skill which children with autism lack a lot. That means imitation means copying someone else, what they're doing, copying a friend, copying a parent, copying a sibling, and then getting creative, changing it a little bit and using it in a creative manner. Now, imitation is also very hard for children with autism. So you have to see, are they imitating? Are they following, especially when they're playing with the parents? A parent might pick up a pencil to do all of that. Is difficult for children. If you go and observe children, you get an idea about how their social competencies are. All right, so like I said, if you want more details, I have put the links on the sides. You will get a lot of information about all the test materials. I'm not going into details of those, but I want you to be able to understand these specific small things that you need to observe. Because if you know a child has difficulty with, let's say, imitation, then you know your goal is going to teach the child to imitate. And we'll talk about how we could do that. Now, if you remember last time, we talked about different severities of ASD based on DSM-5. And it's important to figure out that based on different severities, the way you are going to treat them is going to be different. Your interventions are going to be different. So again, individualistic. It has to be very specific to an individual. It cannot be a program for everybody. It has to differentiate from one person to another person. So we know that there are 3 different levels of autism. We have the high functioning autistic children who have social and communication difficulties and some repetitive behaviors, and they need some support in that. We have children who have substantial difficulties on level 2. They will have social difficulties, communication difficulties, repetitive behaviors, and those are obvious to people. And then we have severely autistic children who is level 3. They need a lot of substantial support, and they have severe difficulties in their social communication and repetitive behaviors. Now, it's important to understand that children that lie on the severe end of the spectrum, level 3, they might not be able to do your cognitive programs because they don't have language enough to be able to handle a cognitive program. What they would need is more like a behavioral program, an ABA kind of a program where they get a reward and they do a particular activity, they have schedules, they have tasks broken down into small steps. And this is something I do not see much in my school. And I'm not going to touch a lot upon this because I would think someone who is a behavior therapist would be someone who has to be involved closely. I'm not saying that special educators and speech therapists do not have anything to do with this group. We still will build their language, we'll still social behaviors, but the way we do it would be different from how we do it for the other 2 groups. And we will teach parents how to work with these children and build reciprocal interaction and imitation skills. But we do not expect them to do very sophisticated social behaviors. Like, we do not expect them to understand some stories where you have to do a lot of inference and you have to think about what the story said and how the characters felt and all of that. We won't expect them to be able to do that because they don't have skills to do that. So this category would be building their basic communication skills, building their basic life skills, going to the toilet, brushing their teeth, getting dressed, and helping them be able to just function at a particular level where they are more or less, they can function all right. They might need a lot of support to get there. But for the other 2 sets of children, and we see a lot of them these days, because also children who have good language and cognition are getting diagnosed with ASD because they have social difficulties and they have difficulties with their repetitive behaviors, or their language, even though it seems age appropriate, might not be because they don't understand inferences. So just to give you an example, I was working with a middle school child, and what happened is, I was explaining to this kid about a gym teacher. We were doing a testing, and the question in the testing was, if a teacher asks you how much salary your dad gets, how can you politely refuse to tell this information to the teacher? Now, this was to test his pragmatic skills, to know what to say, what not to say. And this child is around 15 years old. He can talk, he can read, so he is on the higher functioning side. And instead of telling me how he could politely refuse to tell the teacher about his dad's salary, he says, I don't see anything wrong with telling me, teacher, about my dad's salary. He didn't understand that pragmatically it wasn't right for his teacher to ask his dad's salary. Although he tried to give me the right answer later on how to politely refuse, but in his head, it wasn't wrong. He was just being honest, just straightforward. So even though he's high functioning, he can read, he can talk, he doesn't understand these subtle, small things about language usage. So even the high functioning autistic children sometimes find it really difficult. Can you please close your mic, Mr. Alok?
I'll do that. Yeah.
Okay, thank you. All right. So high functioning autistic children also can have language difficulties, which are subtle, which are small, which you might not be able to understand unless you really look for those things. So this is how we would deal with when we talk about social competencies. We will focus on level 2 and level 1. Severe autistic children most probably would need a behavioristic program. All these sets of kids will need parent training programs. They are really, really strong. They help you achieve your goals so much faster if you involve parents, grandparents, siblings, teachers, everybody who's involved with the child. If you start doing the same thing, you will see a big change in how your children are progressing. Now, I'll briefly tell you about Hanen. This is one of the places you can go to. I'm trained as a Hanen therapist, so I have access to more information than you will be if you're not trained. But even then, if you go to the website, there's amazing information for educators, for speech therapists, for parents to understand how Hanen program works. Now, these programs that I'm talking about are not behavioristic programs. So that means we are not making children do what we want them to do. We are figuring out what children are interested in, and we're helping them do that. So that's why the first point in any Hanen strategies. So Hanen is a non-profit organization in Canada that trains speech and language pathologists, special educators, and sometimes parents. They have different courses to help them work with the children. But when speech and language pathologists get trained, our training is focused on training the parents to work with their children. So the most important thing that we train our parents is to understand what their child is interested in. So that's a really, really important thing, especially with autistic children. You might have seen that, you know, you lay out your table, you put all different things for the children to do, and they are not interested. And you spend half an hour trying to motivate them, trying to persuade them, trying to force them, trying to, you know, give them a reward, and they won't want to do it. That's why the idea is what you're doing is child-oriented strategies. So what you would do is, before you even start working with the child, you will go and observe them in the classroom. You will observe and see what do they want to really do. So if they like playing with cars, when they come out with you, or when you go into the classroom and you want to build a relationship, you want to start teaching them, you will sit down and join them. So you will observe, oh, this child likes playing with cars. I'm going to sit down and play with the cars with the child. And you're going to wait and you're going to listen. You're going to follow the child's lead. So child is the one that you're going to follow around and figure out. Why is that important is because this is building on what the child already has. And then you're going to comment or join in. And one of the very important facts is whether you're doing book reading, whether you're playing with the child, whether you're building social skills, you have to get down at child's level. You have to get down face to face. No sitting on the chair and telling children to do something. If you have a 4-year-old, they are on the carpet, they are playing with the car, you get down and play with them on the carpet with the car. Because that's how you're making it easy for them to see your face, to figure out what happens in a social interaction. So if this child has a few cars, let him have his few cars. I brought a stack of my own cars, 5-7 cars, because you don't want to get into an argument by taking their toys. So bring your own toys. Let them be similar to the toys that the child has. So he had a car, I had a car. So for a few days, I was just racing the car besides him, lying on the floor, running, making the car go back and forth. He started noticing me. He saw what I was doing, and he was looking at me. After a few sessions, he started seeing what I was doing. So then he developed an interest. Then I would say, oh, let's bang the cars together. I would take my car and bang into his car. He suddenly got interested because it was fun. So when can you see the video? Can you see the YouTube video?
Yes, madam. Yes, madam.
Okay. Thank you.
But there is no.
Oh. All right. Let's see if we can do anything. I can't see. Okay. You cannot hear it again. You can't hear it now?
Yeah, ma'am. No, there is an option for
Yes,
your
ma'am.
speaker.
Can you hear
or
it now?
behaviors, this doesn't usually work very well.
Yes, ma'am. We can
If your
hear it
child
now.
has a strong sensory preference,
Okay.
he'll likely find another way to meet this need. What would actually work better is if you can use these sensory preferences in interactive games that you can play together with your child. Today, we're going to talk about how you can create fun and interactive games that incorporate your child's sensory needs, so that you're not only satisfying your child's sensory need, but you're also creating opportunities for communication and interaction. These games are called people games. People games are games without toys. You just need two people. Some people games involve music and movement, as in games like Ring Around the Rosie. And some people games just have movement or action, like as in Tickle or Chase. What's great about people games is they naturally incorporate your child's sensory preferences. This will likely motivate your child to stay in the interaction. Play the game several times. Don't be afraid to play the game over and over if your child likes it. The more he plays the game, the more familiar he'll become with it. Tip number 4, give your child a chance to participate in his own way. Once your child's familiar with the game, create opportunities for him to do. For example, if you're swinging him in the blanket, pause every once in a while and see if he'll say something to keep the game going, or maybe do something like give you the corner of the blanket. Tip number 5, help your child send a message. If you pause during the game and your child does well, you could model the word go. You could point or gesture to the blanket, or you could even physically help him hand you part of the blanket to keep the game going. Tip number 6, end the game the same way each time. When your child walks away or indicates that he no longer wants to play the game, you can say or do something to mark the end of that game. You could, for example, say all done, sign or use a gesture to show that you're finished the game. And by ending the game in the same way, you're giving your child a model that he can eventually use himself to end the game. Sometimes it might be hard to get a people game going with your child. It may be that you've thought of the sensory preferences and thought of a game that might work, but it's really just not working with your child. And sometimes it's actually hard to think of a game that incorporates your child's sensory preferences. It's always helpful to consult a professional who can help you work specifically with your child. In particular, speech language.
Okay, so you have now seen about this video, which talks about how to use different games with your children. You can do any kind of game. Like I talked to you about the car game, and she was talking about the blanket game, and so many games. Remember, like she said, you have to incorporate the child's sensory needs. That means some children want are hypersensitive. Some people are hyposensitive. You have to figure out what they want to do. Some people have too much of sensation, they close their ears, but some people keep running around all the time. That means they're not getting enough sensation. So you can choose games based on that, and then gradually you can include more and more people into this game, and then it becomes a social activity. From a repetitive behavior, a child who runs or who does something with his fingers all the time, you can change it from a repetitive activity into a into something that makes sense, something where people are playing back and forth. Now, I already talked to you a little bit about, going to go into a little more detail now. Like I said, social thinking program is for children who have normal or near normal language skills. What we mean by near normal is, they can talk, they can most of what is said, but they might have small difficulties here and there. Why is that important? Is we pick them out in the school. And I would just ask them to observe people. We might observe people doing physical education program. We might observe people doing music. We might observe people in the playground. We might observe people in the class. And we talk about what the group plan is. In playground, you can run around, you can shout, you can have fun. In the classroom, you cannot use a loud voice. You have to listen to your teacher. That's what the group plan is. Then we would break down the group plan. And then we would help them join the group plan. And then when we are working on this particular skill, how can teachers help? They can be a part of your plan. So you say, oh, I think this child needs to learn about group plan. This is how I'm going to teach him. We are going to do observations and we are going to go around. We are going to figure out group plan. We are going to look at the videos. We are going to try and join a group plan. But the teacher in the class will also use the same language. The teacher will say, our group plan for today is, we are going to have an assembly in the morning, then we have reading, then we have recess, then math, and then it's home time. So if you have a group plan like that, kids understand. And you can tell them, you can say, oh, I can see you don't want to be a part of the group plan. But most of the kids do want to be a part of the group plan. It's just that they don't know how. And you can, any of the 10 concepts, I would ideally say start with the first one. Because you might imagine that the child knows that other people are thinking thoughts, they have feelings, they don't know that. So you can teach them emotions, you can teach them words for feelings, and if marking them, you talk about cars. If the child likes comics, you go and find out more about it. If they like about superheroes, find about superheroes, read about dinosaurs, read about Pokemon, build a relationship with the child. That's your starting point. That's, if you don't build a relationship in doing that, ask parents, what are they interested in? Sometimes what I do is, I have this child who loves dinosaurs. So we get a dinosaur book every time he comes and works with me. So I say, let's work for 15 minutes, then we can look at the book together. So he is passionate about it. He's very knowledgeable about it. We're not taking it away from him. It can become difficult for him to understand other people's perspective because he's always thinking about dinosaurs, but you can also turn it into a strength. So, and then use those strategies. And you can see a link down there which talks about 10 more ideas about inclusive classrooms. So take a look at it when you have time. Now, I'm going to give you an example here, a clinical example of a child that I worked with. So this is a 6-year-old ASD kid who, if I go into the playground, she's not playing with anybody. He's sad, his head is down, he's walking around all by himself. So the first thing I did was look at what other kids of his age were doing. Was everybody walking around by themselves? Then that's okay. He's not doing anything wrong. But gradually he started saying, oh, I really want to play. Nobody plays with me. So then we made a social story, and I'll talk a little bit about the social story. We made a social story to explain how it all works. So sometimes when I work on math, I get upset or I get frustrated. For example, let's imagine that working on math is our problem. You might say, my name is this, I am in this school. And then you say, sometimes when I feel frustrated or upset when I work on frustrated. Then you say, it's okay to feel frustrated, but I need to stop and calm, take a deep breath. I'll remember to talk to my teachers. When I am able to keep calm, I and my friends feel happy, and they feel the social situation when your child is very angry, is in a state of meltdown. These have to be used all the time. They have to start learning. You can make a social story about anything. It can be a social story about bus ride in Corona time. It can be how much language you put there depends on. So then you take a video of other children playing hide and seek, and then you talk about how hide and seek works. Then you practice it with that child, and then you start talking about that. Then you start sending the child out with a smaller group, then bigger group, and gradually you have to make it easy. Next one is playing your parents' exercises at home to help with sensory difficulties. Do people with autism spectrum disorder always suffer from intellectual disabilities? No, they don't. You can smart ASD children. And there are people who have been inventors and great researchers who are thought to have had ASD. So ASD doesn't mean intellectual disability, but yes, you can have comorbid. That means ASD and intellectual disability can occur together. So they don't have to have it, but they can co-occur. It can be a comorbid disorder. Can you give address of Hanen Center in Canada? Please go to hanen.org, and there they will be able to tell you all the Hanen certified therapists around the world. I know there are Hanen certified therapists also in India. So it doesn't matter where you want the Hanen therapist from, go to the website hanen.org. It's again there in my presentation. Look for certified therapists from across the world. You can look up anybody that you like. And I highly recommend Hanen therapy, especially if you're a parent. It's the best tool you can have. I think I'm going to take 3 more questions, because I don't want to run over the time. Next one is by Kishore. It says, how do we do sensory integration with ASD children? So when you're playing games, when you're teaching children to play games, take their sensory preferences into consideration. If a child has sensitive and loves running, do a running game. If the child has sensations, needs tactile sensation, then play a tactile game. So it depends on what the sensory profile is. And like I said, if you have access to an OT, let them do an evaluation. That will give you so much of useful information to use in your social skills and communication skills with the child. Okay, 2 more questions. Next is by Benny. It says how to create communication for ASD children initially. See, you cannot force children to talk. So be very careful about and clear about that. You cannot force any child to talk. ASD or not, normal children, they cannot be forced. So create circumstances for them where they want to communicate with you. So like I explained with this child who wasn't talking much, just playing with his car, I sat down and played with him. It became fun. I gradually started adding words. And that's what you need to do. You need to make communication knowledge. There isn't, so far, there isn't one thing that can cure your autistic child. And I wouldn't say cure, because, they're special in their own ways. They're smart in their own ways. So what you need to do is identify your child's needs and work. You as a parent want to get really medicine you have for your kid. Okay, I seem to be exceeding into Kala's time. So I'm going to stop here. Thank you for listening. Thank you for today.
So that was a very practical and insightful presentation to all of us. Thank you once again, ma'am, for making this session a fruitful one. Yeah, thank you so much, ma'am. Yeah. Now let's move on to the next session for the day. Let me invite Dr. Kala, ma'am, who's the next speaker. She has a PhD in ASLP interdisciplinary, where she worked on remediation of phonological process in children with cerebral palsy. She's working as an assistant professor in speech and hearing department in clinical teaching research for the past 18 years. She's a Hanen certified SLP and reviewer in 2 international journals, published more than 15 papers in peer-reviewed international journals. She has coordinated CRE programs recognized by RCI and presented more than 22 scientific research papers in national and international conferences. She is an RCI visiting expert for the Institute to New and Extension UG and PG ASLP programs. I think somebody has unmuted their audio. Kindly mute your audio and video. Yeah. Ma'am will be talking on assessment and management of communication skills in children with autism spectrum disorders. where we'll be learning about the assessment and management of communication needs in children with ASD. Yeah, now the session is over to you, ma'am.
Thank you, Gayatri. Is it audible?
Yes, ma'am.
Okay.
Yes, ma'am.
Yes. Okay. So today the topic of my presentation is assessment and management of communication skills in children with autism spectrum disorders. My content outline, I'll be talking about introduction, what are the communication challenges in ASD, communication frustrations in ASD, assessment of screening instruments, autism specific and assessment of language in ASD, general and evidence-based management strategies in ASD, intervention strategies for non-verbal, echolalia, and verbal children with ASD. Introduction. Autism spectrum disorders are a group of developmental disorders of unknown origin that affect children in many important areas, namely, language has increased in recent years, and this interact with their environment. Our mission as a therapist is to recognize their difficulties and try to enter their world in order to increase their communication and relationship skills. Therefore, it is essential to carefully observe the child, taking notes and measuring his or her abilities through the use of ASD-specific and general evaluation scales. This initial assessment of child's situation is critical in order to follow and measure his or her improvements and focus the therapy based on the results. What are the communication challenges in ASD? They'll have difficulties with the non-verbal communications, delay in expressive language skills, presence of echolalia, restricted vocabulary, inappropriate facial expressions, lack my mind, but I just could not get something. I often screamed. I screamed because it was the only way I could communicate, only way I could express my displeasure. If I did not, my desire not to wear the hat was to throw it on the floor and scream. Being unable to talk was utter frustration. The speech therapist had to put me in a slight stress state so I could get the words out. She knew just how much to intrude. If she pushed too hard, I would have a tantrum. If she did not push enough, there was no progress. Often, I would space out and speech therapist would jerk me back to reality. What are the goals? Focusing on development of receptive. Our instruction should emphasize on paying attention, imitation, comprehension of common words and instructions, using language for social reasons, and functional communication. So, our communication goals should emphasize the functional use of language and communication in various settings. Moving on to the assessment, each child has a unique pattern of language rules and behaviors to be revealed and described. The SLP should keep in mind why, what, and how of assessment. Considering why the child is being assessed, it helps the SLP to clarify the purpose. This clarity in turn enables the SLP to decide what specific behaviors to assess and the best evaluative methods to use. The assessment may be grouped into identification of the children with potential problems, establishment of the baseline functioning, and measurement of the change. So the baseline functioning enables the SLP to determine the present level of performance, the extent of the language impairment, and the nature of the problem. So we start with the screening. Screening procedures evaluate the main characteristics that differentiate ASD from other developmental disorders, including difficulties in eye gaze, orienting to one's name, pointing to or showing objects of interest, written play, imitation, non-verbal communication, and language development. So moving on to the comprehensive speech and language assessment. This includes relevant case history, including child's health, developmental and behavioral history, and current medical status, medical and mental health history of the family, including history of siblings with ASD, medical evaluations including general physical and neurodevelopmental examinations and vision testing, formal and in speech and language assessment, including assessment of motor speech abilities, feeding and swallowing assessment as needed, AAC assessment as needed to determine the potential benefits for improving functional communication. Audiological assessment by an audiologist if needed. Assessment of speech and language. Language is assessed depending upon the child's age and abilities. The SLP assesses the following language skills, including spoken language. This includes expressive and receptive language, then communicative intent, current means of communication and their effectiveness, whether verbal or non-verbal, vocabulary size and word type used and understood, word combinations and grammatical forms, whether they used or understood, ability to follow commands, ability to respond to yes-no questions, and ability to correctly point to objects, words, and pictures. Then, pragmatics, including discourse level language levels, including conversation, narrative skills, describing, explaining something about it, etc. Then, OPM examinations, assessing the structures and functions of the oral mechanisms. These are the structured assessments, what we use it. Like there are some screening tools are available, diagnostics tools, behavioral problem assessment tools, and we have developmental assessment tools, family stress assessment tools, and additional tools also available. These are the recommended screening instruments for autism. I'm not going into a very detail because everybody knows about it. The first one is the chart, checklist for autism in toddlers. Age ranges 18 months to 24 months we can use it, and this has 2 sections and it is a questionnaire based. It takes 5 minutes. You have to see whether this is pass or fail, and it is freely downloadable. And the next one is the M chart. This can be used from 16 months to 4 years. Again, this normally developing children and consists of 23 yes no questions. Again, it will be taking 5 to 10 minutes. It can be downloaded. And social communication questionnaire, above 4 years you can use it. And this has a parent completed questionnaire consisting of 40 yes no questions designed to identify children as at risk for autism spectrum disorders. And this is available in 2 forms. One is the lifetime form focus on the child's entire developmental history, and the current or the most recent 3 months period. And this can be finished in 5 to 10 minutes, and this scoring will be pass or fail, and this you have to purchase it. And recommended screening instruments for autism continued, early screening for autism triads, pervasive developmental disorder screening test, social responsiveness scale, screening tool for autism in 2 years old. So this can be used like 14 to 15 months. All are parental questionnaires, and it takes 5 to 20 minutes. And the last one is the testing. Then autism specific assessment instruments, autism diagnostic observation schedule, autism diagnostic interview revised, autism observation scale for infants, and childhood autism rating scale 2. So these are the details. You can see it in Google. And there is a GARS 1, GARS 2, and GARS 3. And it has 56 clearly stated items. It describes the characteristic behaviors of persons with ASD, and it's grouped into 6 subscales: restrictive, repetitive behaviors, social interactions, social communication, emotional responses, cognitive style, and maladaptive speech. It is an efficient method for assessing the probability and severity of the ASD. Then autism diagnostic observation schedule. It assesses social behavior, joint attention, imitation, requesting, reciprocity, use of vocalization and speech and gesture in social situations, play and interest. Then autism diagnostic interview revised. It has the 3 headings: early developmental domains, communication domain, social development, and play domain. And these are the instruments we specifically use it for language domain. So test of language competence, preschool language scale, clinical evaluation of language fundamentals, P-body picture vocabulary test, expressive one-word picture vocabulary, children's communication checklist, comprehensive assessment of spoken language. So these are the details I've given. This is a test of pragmatic language and the second edition. It identifies individuals with pragmatic language deficits and it determines individuals' strengths and weaknesses. It documents an individual's progress and researches pragmatic language skills, etc. Bailey scale of infant's development. It assesses motor, fine and gross motor, language, receptive and expressive, and cognitive development in infant and toddlers. Age ranges from 0 to 3 years. Then pre-linguistic autism diagnostic observation scale. It is a version of the ADOS modified to diagnose young children under the age of 6 years who are not yet using phrase level speech. It is a semi-structured assessment of play, interaction, and social communication. Then we can also use reels, receptive, expressive, emergent language, and reels extended till 7 years. Three-dimensional language acquisition, then COMDEAL, developmental checklist. Then there is a clinical evaluation of language fundamentals. As a summary, the common impairment observed in children with ASD is in the functional use of communication, but the mean length of utterance and the vocabulary should also always be assessed. The specific groups like verbal and non-verbal and situations, individual specific, individual or group or familiar or non-familiar should be specifically considered during assessment. Samples of spontaneous communication may provide data to objective measures of functional communicative profile, linguistic complexity, and vocabulary that can be considered in the overall diagnosis as well as in the intervention planning. Moving on to the management. From the 1960s through the 1970s, research into treatments for autism focused on medications such as electric shock and behavioral change techniques. Later relied on pain and punishment. During the 1980s and 1990s, the role of behavioral therapy and the use of highly controlled learning environments emerged as a primary treatments for many forms of autism and related conditions. Currently, the cornerstone and language therapy. Effective interventions in ASD have the following common characteristics. It should be started at younger than 3 years, intensive therapy, greater than 20 hours per week, parental involvement as a sport therapist, and it should deliver in a natural setting, in the home, school, etc. The increased prevalence of autism has intensified the demand for effective educational and therapeutic services, and intervention science is providing evidence about which intervention are effective. So, the intervention process will take place in 3 steps. One is the conduct assessment. Second step, develop intervention plan, identify goals, select interventions, determine procedures for monitoring progress. Then third step, monitor the progress. So what are the things we have to consider before starting the communication therapy or speech and language therapy? Features of a communication program: setting up a communicative situation. Then use of abundant gesture and facial expressions to capture child's attention and foster language acquisition. Minimize direct questions. Commenting, providing commentary about the child's internal dialogue, which promotes language development. Model it, reducing it. Reduction the complexity of the language, maximize the child's comprehension. Use of exaggerated intonation, volume, and rate of speech, which directs the child's attention to keywords. General principle integrated into the daily naturalistic routine rather than specific therapy time. All family members should be involved in training the family. Child should be immediately and consistently reinforced, social or material based, upon completion of task. Tasks should be planned keeping the content and the lights in mind. So what are the intervention to facilitate communication skills? These are the intervention initially informed by the child's current level of communication skills, irrespective of the age, and then progress to higher levels. So the first technique is the speech stimulation. So we say as a speech language pathologist, like we tell the parents, you talk. So the parent should speak more around the child. Whatever the child is doing, we have to talk about it. Then second one is the parallel talk. Parents are advised to repeat bisyllables or other sounds or words that the child is uttering in the same tone and prosody. We have to repeat it. This teaches the child the concept of reciprocity in communication as well as encourages the further vocalization. Then create opportunities for communication in daily routine. So keep the preferred toys or foods items out of reach of the child. Then create an opportunity for the child to request for the same. While engaging in play, pause for some time to make the child to anticipate and request parents to continue the play. Example, pausing the child's favorite song in between. Then parent blows bubbles only after child looks at their face during bubble game. Hold the toy child is playing with and only return it once the child asks for it. Then oromotor exercises, if needed, you can do it. If the child is having any chewing problem or sucking problem, so you can improve some of the vegetative exercises. You can blow bubbles, straw drinking, feeding skills. Then if needed, you can give some massages, etc., passive massages, etc. If the child is having sensory issues, they have whether tactile, proprioceptive or anything, and you have to accordingly you have to give oromotor exercises. Then improving the child's understanding. Use simple short instructions, familiar phrases, and getting the child's attention by saying his or her name at the start of an instruction must become a part of the regular routine. Example, wave bye to daddy, wear your shoes, time to eat. Give clear, direct, specific instructions rather than vague suggestions like rather than shall we sleep, like questioning skills. Then naming and labeling, parents should name each object explicitly while the child is handling or playing with an object. Example, this is a car, as well as real objects you can use it. Choice making. So ask a child to choose among options. You can give two objects. You can ask a child to choose to request for something. You have pointed. Then next one is parents should offer objects to the child that they know the child's dislikes. So the parents then encourage and model with dislikes. Immediately remove that item after child makes a gesture or refusal. Then phone games. Parents and child engages in imaginary telephonic conversation using toy phone. So this can be used to teach basic greeting skills, turn taking skills during conversation and understanding another person's feelings, etc. Then pronoun reversal. Children with ASD often make errors in correct use of pronouns. Parents should use frequent physical prompts, touching the child while saying I, then me, then mine, and model correct interaction using other person's pronouns. Then sequencing skills. The parents can help the child to recall recent past events and describe them in the correct order with a minimal prompt. Next one is the story sessions. Story sessions include reading out a story to a child, understanding a story through pictures, discussion about it, main characteristics, and moral of the story, etc. You can be explained. And social script, there's all social stories, social scripts, everything already spoken by Dr. Sapna ma'am. So I'm not going to in detail. Social stories, scrapbook, photos and materials, drawings and notes are helpful tool of expression and increase creativity. AAC, this also facilitates speech development rather than hamper it. To understand and respond verbally. These strategies are especially helpful in case verbal. Then enhancing ASD, our goal is to improve their expression of communicative. Begin that intent by reaching child, observe the item. The second stage, the child reaching it and looking at the last stage occurs when the child vocalizes and uses words too. So like that, from simpler to higher level, you have to increase. Then ways to modifying routines. How to modify the routines there. Mislabeling objects, calling a cup and anything objects inaccessible, placing a desired object in a closed plastic bag, then making the child to, asking the child to open or waiting for the child to ask for it. Then violating object function, trying to pour from a closed bottle. And then whether you have to notice whether the child is looking at you or asking something or intending communicating, everything you have to observe, and appropriately you have to respond it. Then pictures as a communication. Many children with autism spectrum disorders are much stronger visually than they are verbally. The following approaches focus on teaching communication skills through the use of visual icons for those children who are visually strong and who are pre-verbal. Visual interaction augmentation, a strategy in which pictures of desired objects are exchanged by the child for the desired object itself. That is picture exchange communication system. So it has six levels. The phase 1 performs the basic exchange with a wide range of pictures. Phase 2 persists in getting an adult's or peer attention. Then third one is discrimination between the number of picture in array. Then fourth phase is form sentences using pictures. Fifth one is answers questions and using pictures. What do you want, etc. Expand. Then sixth one is they expand on previously mastered items, like what do you see, what do you have, what is this, like that you can increase the communication. Then applications of picture-based communication system, and it is a sensory motor learning of word meaning, sequencing pictures you can ask them to do, placing picture in context. Example, a photo of an individual serving apple juice should be attached to the door of the refrigerator. If that is where the boxes of juice are kept, like that, the child will be coming to know. Then facilitated communication, may use objects or pictures or symbols to indicate their likes and dislikes, while others are able to communicate through writing or typing. Then picture communication for verbal children, fading the picture communication. The use of icons should be faded gradually, with some icons being taken away as the child demonstrates an ability to verbalize. When the child started speaking, vocalizing, then you have to fade the icons. The child should now will be able to give a word or a word approximation in place of icon. Then verbalization should be differentially positively reinforced. Then methods to enhance communication in verbal children, expand pragmatic base, provide dialogue scripts, build interactive scripts around routines, act out children's stories, engage in reciprocal reading, build themes across activities, encourage replica play, videotape discourse, and provide referential communication tasks. Then, intervention for echolalia. As we all know, echolalia is a repetition of other speech. Whatever we say, the child will repeat the same thing. It can be immediate and delayed. What are the functions of echolalia? It promotes developmental changes in echolalia over time. Positive indicator for further growth. Serve a variety of instrumental, cognitive, and social purpose for autistic children in naturalistic environment. Advancing linguistic processing, words, phrases, or sentences are initially learned and retained in an unanalyzed manner. The child moves from using primary pure form of echolalia to mitigated echolalia to eventual creative and flexible verbal productions. Then mitigated echolalia aids in increased flexibility in the application of meaning and sentence structure. What are the variables associated with the higher incidences of echolalia? Situational variables. If there is an environment is unstructured, unpredictable, unfamiliar task, difficult task, they will be having echolalia. Then interactional variables, complex linguistic input. If they are not able to understand the command what we say, so echolalia will be occurring. Then partners directive interactional style. So whoever is talking, then there will be echolalia and other. So you have to many ways, many situations with many people. So how the child, when the child is getting the echolalia, everything you have to observe and assess it. How do we collect the language sample? Use of familiar routines, toys, and children, and create communicative opportunities. Request that the interactions communicate naturally using both adult directive and facilitative styles. And collect sample in a variety of settings that include different activities and document significant non-verbal as well as verbal behaviors. So, after collection of the language samples, you can give indirect intervention strategies and direct intervention strategies. Indirect intervention strategies, communication among interactants, modification of the environment, simplified language input, varied adult verbal interaction styles, and modeling you can give. Directly, Directly responding to and promoting communicative intent, advancing linguistic processing, and you can also use AAC. So these are the indirect intervention strategies: increase communication among all interactants regarding assessment results and intervention strategies, modify environment to increase the predictability and consistency while reducing highly confusing and arousing situations, simplify language input to match child's level of linguistic processing, vary adult verbal interaction style to reduce cognitive, social, and communicative demands, and promote a variety of pragmatic functions. For early language users, model conventional and relevant utterances that can be easily borrowed and eventually converted into more sophisticated forms. Direct intervention strategy: acknowledge and appropriately respond to echoic utterance that are used in and model conventional and appropriate utterances to promote specific communicative functions, provide systematic modifications that serve to reduce, replace, or expand constituent part of the echoid phrase to promote increased linguistic processing and creativity. And you can also use EAC. So what are the techniques? Teaching verbal imitation skills, prompting, prompt fading, pausing prompts, example say, then you say wait for the child's response, then chips. If the child responded with echolalia, the clinician used carrier phrase in a hierarchy of verbal imitation, verbal modeling, and phonemic cueing. Example, I want chips. The child will repeat same thing. Then you say, you give a prompt like I want, you give a pause, then wait for the child's response. And the next trial, the clinician would say I, the first phoneme you have to prompt it, I, woo, then wait for the child's response. This would continue if necessary until the child responded appropriately without cueing. So timeout and verbal instructions such as don't echo it. Then next technique, echoing, just to repeat whatever the child says. And response distraction, I'm hungry. Say to the child, do you want some biscuits? A short pause. I want biscuits. You give some pause, then you say, I want biscuits. So wait for the child to repeat the phrase, I want phrases. In order to avoid confusion, trying using simple words, and instead allow the child to process the information to respond. So you wait for it. Pragmatic developmental approaches, when you already children process information. The following recommendations can include sit face to face with the child during play, observe how the child describe the play, reinforce the play, model pretend play, able to play games with one adult, involve other children gradually, then move the play from the parent child due to child peer and later into group. Developing interactive play, imitation, play routines, set songs for it, and develop give and take. And developing simple play structures, you can parallel play, play dialogues, script and social stories, everything. You can add everything to it. Then you can improve simple play. Then developing symbolic and pretend play, an adult modeling a number of pretend play scenarios in front of a group of children, encouraging children to imitate and extend the play sceneries in pairs or individually. New materials and new scenarios are modeled for children in later sessions. Non-representational play materials are core features of symbolic play. Then developing social play, social integration in play groups can be used prompt, produce, and extend play routines. Sideboard reading, and that the child has achieved decoding and sequencing sounds partly. So autistic children who learn to talk using picture-based communication system are primed and perform well with this approach. Then these are the intervention strategies, significantly evidence-based, scientifically proved, ABA, applied behavior analysis. So here I'm not going into a very detail. You have to see the process of applying behavioral principles to change specific behavior and simultaneously evaluating the effectiveness of the intervention. It emphasizes both prevention and remediation of the problem behaviors. We have to give attention is given to social and physical environment, including antecedent conditions, consequences that elicit the maintained behavior, etc. Then other ABA interventions, programs, discrete trial training, you have to give prompting, shading, shaping, effortless learning, extension, punishment, etc. Then functional communication training, pivotal response training, other specific ABA strategies like early intensive interventions, other evidence-based interventions like AAC, picture exchange communication system, modeling, visual supports, computer-aided instructions, parent-implemented interventions, then intervention with promising or emerging evidences, play therapy, supportive therapies. So, take-home messages, the earlier one can be diagnosed, the better the interventions for the child. The early interventions are available for children with ASD and have been shown to improve functional outcomes by providing parents with guidance and training and engaging their communication in intense social engagement and interaction. The children can do productive, functional members of society with ongoing support. Thank you. These are my references.
Yeah, thank you, ma'am.
Yeah.
Thank you for your informative and interactive session, ma'am. Next, move on to the third. Mr. Dhanavandan sir will take over the stage.
Yes.
Thank
Yeah.
you.
Yeah. Thank you. Thank you. Moving on to the third session, Sri K.K. Dhanavandan, working as a special educator for cerebral palsy at NIEPMD. He has 23 years of service in the field of special education, teaching and training children with cerebral palsy and multiple disabilities. He has published more than 10 research articles in peer-reviewed journals. He presented more than 21 papers in the national conferences and international conferences. He was a member in curriculum development process, D.Ed special education, M.Ed special education, and D.Ed special educations. He was a resource person and coordinated RCA CRE programs. He served as a coordinator for RCA, D.Ed special education, CP, program CP, NIOS, and faculty for pedagogical paper in D.Ed and M.Ed special education. Served as a technical person for selection of special educator on Pondicherry for Department of Education to place a SSA technical member for development of overseas curriculum for D.Ed special education, MD, B.Ed special education MD at Annamalai University. Over to you, sir.
Thank you, madam. Thank you, madam. Is it audible?
Yes, sir. Yes, sir. Yes, sir.
Okay, thank you. Can you able to see? No, no. And expressive attention in the classroom. The tool also has these skills. And Vineland social maturity scale we related to the triad of impairment, which is Indian adaptation, Dr. Bharatraj, where starts from 0 age to 15 years and knowing the social age and finding the social quotient. And developmental assessment of young children, where the programs constructed like social emotional skills, physical development skills, communication skills, cognitive and self-help skills. See, these assessed through the assessment checklist, the tools available in the area where we have to assess the child abilities. Identifying the child levels of learning, how we will be identifying the level through the assessment. The teacher may test, we can develop some of the teachers because we unable to purchase the tools where it is available costly also to assess what we are supposed to, how the child is indicating his needs, how he or she is dependency in the skills area and how she is independent in some of the area where using adaptation or not. These skills the teacher may test can be helpful for the child to assess. The matching skills, how he is doing matching or sorting skills, identification, naming and generalization skills, which we see most of the special educators, we teach all the skills every day, day-to-day basis. We teach matching skills, shortening skills, identification, naming. But finally, the generalization, where we supposed to take the child one step ahead, the generalization is missing. Generalization, which is the same color which is available in the soap, dress, or bindi, or banana, or the food items, where the child is supposed to learn, generalization is missing. We have to do it. Otherwise, the matching shorting identification only happen because the child with non-verbal, child with autism, naming and generalization will not be happen. So whether the child level is in, whether she is a starting level, acquisition level, or fluency level, or he is in maintenance level, or he may be in the generalization, where the child is need the support, because learning first stage is acquisition. If he acquired the learning, then make the child to learn fluent enough. If suppose color concept or number concept or pre-academic skills or pre-academic, pre-reading, pre-writing, or maybe the child in the basic academic skills, make the child to fluent enough in that particular skills. Then make the child to everyday practice, like it maintain. That's what it is, goes to the chaining activity, where backward chaining, forward chaining, maintaining that the skills shaping is happened. And the generalization, where you need to make generalize the things, which is, when we purchase a food, it is also food. When we are having the food at marriage hall, it is a food. When we are making, mother is making the food at home, also it's food. They have to generalize these things. Then you have to see that why of learning, then how of learning, and what of learning, why we need to teach, and why I supposed to learn. The teacher is every day she or he is teaching the color concept, number concept, shapes, or writing, pre-writing, strokes, different strokes, circle, or whatever the shapes I'm doing it every day, he is making it. Why it is going to be, why I am learning, how the learning supposed to be happen, what I supposed to teach. So to improve the skill acquisition and independence, because most importantly, make the child independent. That is right from the beginning, which we are making it. The child is supposed to be independent enough in his all the skills. That's what we are making why of learning. How of learning? Through the teacher making different teaching methods, which is, is taking the child around the classroom, around the environment, the methodology, what we are using it, and that techniques, simple to complex, known to unknown, concrete, abstract, like this, the techniques, the procedure, making it, the principles which is helping the child to learn. What of learning? All the areas which is related to ADS intervention, which is available in children with ASD. Support the child needs, whether the child needs support intermittent or temporarily, it is a time basis or limited, or it may be extensive, more support is needed, or pervasive support. It is the child is totally independent, I need to do a pervasive support. So how I am going to do it? UDL based learning, how of learning, what of learning, which will be expression, which is happen in that. So profiling the child's strength and weakness, because we know that all the areas of concern, because the child is a all to the sorry, is it no?
Yeah, hello.
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 I'm connected.
Yeah, it's audible, sir.
It's
Yeah,
audible.
yes,
Is
sir.
it?
Yes, sir, audible. Continue, sir.
Okay. The slides are visible, ma?
Yeah, yes, sir, visible.
Okay. Sorry. Okay. Thank you. The research, the current research demonstrates that ASDs are due to alteration in brain function. You see that alteration in brain function. In other words, they are brain-based disorder, because neurological disorder, neurological based disorder, like that. We used to say that The interaction of the inducer biological formation of complex interconnected brain system and molds the efficiency of the brain process and connectivity. Because everything it is, we used to say plasticity, neural plasticity. A physical therapist, an occupational therapist, and a speech pathologist, everybody, counseling psychologists or clinical psychologists, they do making the child to do it, demand something. They make the child to do it with a reward. Why it is happening? Why they are making it? Because it is an interaction between the activity and brain. Hari? The interaction between the activity and the response to registered in the brain. That's what the brain system is most important. You see why the brain is needed for learning, why they are repeatedly doing it. There is no one size fits all the approach to intervention of person with ASD, because it's true. There is no, it is a tailor-made program. A child with autism is different from X child or Y child. So they are very significantly, because a child with Asperger's syndrome, high cognitive skills, they can speak, they do echolalia. A child with lower cognitive functioning, they may not start anything, only pointing or pulling or pushing or biting instead of getting something. I'm unable to communicate. The areas of development that may be impacted by ASDs. You'll see that the brain and the learning. Why the brain is most important for learning? Because we are doing it as a special educator. We need to know brain and function. Is it necessary? Because the RCA curriculum previously, the neuro development, brain and development. Previously, the neuro development, brain and development, and the cerebrum, everything we have studied. Now it is minimized. The curriculum was minimized. We have to learn, because we are making the brain to understand the everyday learning, everyday teaching of the child. The cerebrum, it's mainly concerned, or maybe mainly it is responsible for memory, personality, and intelligence. Because we have to see the memory. Why memory? Every day as a teacher, I am teaching the concept of color, name, size, shape, cold, hot. This is a heart. This is a long, tall. This is a dog. This is a computer. Computer, you can do it. Play. So it is responsible for the memory where I'm teaching. It's supposed to go and stored in the short-term memory to sensory memory to short-term memory to long-term memory. It's permanently stored, and whenever it is needed from the long-term memory, and it is answered immediately. Consciousness. Okay. Then the cerebral cortex, which is mainly responsible for sensory areas that deal with the perception of sensory information. Because child with autism, always there is sensory overactive or sensory underactive, where the occupational therapist used to say hypersensitivity, hyposensitivity. Where the problem is, see, the perception and sensory information is stored through the cerebral cortex. It's control the voluntary movement. Some of the children with autism have some problem in executing. When I'm throwing a ball, they're unable to catch. The ball goes out, then they will catch. So this is executing an execution problem, where the association area is integrating the complex function of motor movements. Cerebellum, where we see that's only it may taking care of balance. No, it is sees that it is role of language processing and recognition, because whatever the mother is telling, he has to understand through them. We go, sit, don't. Then frontal lobe, which is in the front brain, where you can see the picture, thinking, planning, short-term memory, execution, planning, and everything is there. So when it is associated with the executive function, motor performance and reproduction of language. Executive function, mostly that children with autism, they have problem in executive function deficit. So in the primary motor cortex, where motor performance, initiating of voluntary movements, as well as premotor and supplementary motor areas, which is coordinate, planning and initiation of voluntary movements. When the child is standing in the playground, where the special educator or mother, they want to make the child to run when the whistle was started. Run, 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 run. We used to jump, we used to shout, we may push the child, run, run. But he didn't know that running means we have to go with the child, hold the hand, run with the child. Then only you know that running means running. This is running. I supposed to push forward, initiation of voluntary movement. That it is initiation. There is a problem in initiating that activity. It is responsible for frontal lobe. But the Broca's area, most of the communication therapists, speech language pathologists, and the counselors, clinical psychologists, they used to do production of language. Broca's area, where the motor area, it's responsible for language. When it is damaged, understand the patient understand many written and spoken word, but has difficulty speaking. The speaking is a problem. The parietal lobe, which is a motor cortex area associated with integrating sensory information. The parietal lobe deals with other information, which is sensation, which is we say that they have a sensory overload, touch, pressure, pain, heat, cold, tension. These are the things which is associated with the parietal lobe. It is spatial orientation. It is the child with autism, sometimes he may cross the road without a mother help, without anybody's supervision. So the spatial orientation, the bike is coming, the auto is coming, they don't know where the distance, how much distance it's coming, how distance is, how far away it is. Then involving the comprehension of language, concern with processing of proprioceptive and tactile stimuli. Most of the children, they have a proprioceptive, grinding teeth is there, tactile defensiveness is there. They are not holding the pen for me to write, because we used to say teaching in the classroom as a special education teacher, I need to do a writing skills. If the child may not be interested in writing skills, why should I bother about that? We can train the child starting from the smaller age also. His interest, drawing, painting, play, or whatever the interest activity is supposed to make the child to do. And we know people are here in the pandemic situation. We depend on cooker repair, a gas stove repair, a person who is a mason, a person who is a plumber, a person who is needed electrician. So what my child is best on safe mode training. We can train the child if the child is failed to achieve the academic skills. We have to switch over the skills for the child need and his independencies. Then spatial orientation and directing attention, and the vernix area, which you see the parietal lobe involved in recalling, recognizing and interpreting words, which is told, which is said by the mother, or that already the speech pathologist madam told that when you given the echolalia, you have to ask, you have to phrase a sentence or word, then he had to recognize and interpret that it is meaning to. So it is responsible for the parietal lobe. The angular inability to write. See, as a inability to write, where the problem is angular gyrus. If I get affected, inability to write and inability to perform arithmetic, difficulty recognizing which finger is which, trouble differentiating the right from the left side of the body, abnormalities of body image. Most of the children with autism, they have a poor body image, as said by occupational therapists, and the spatial relationship also is a problem. So we have to study the brain and the function related to teaching and learning that activity. Occipital lobe, if that occipital lobe is mainly concerned for visual functions, containing primary visual cortex, majority of visual information, receiving the information, understanding the information, and processing the visual information effectively. If damaged, they're unable to perceive color, shape. It's the problem, because if the occipital lobe is major affected, maybe the visual area is gone, that they will be called total blind. But if the problem is there, the insult is there, but they are unable to do it. Color, shape, dimension, and size, recognition familiar object and faces, recognize, read written word, object. If suppose inability to detect that object, maybe it is moving, I am unable to accept, identify. Difficulty reading or writing. For example, the word may appear to move on the page. Maybe the child unable to read because they are seeing that word is moving. Difficulty locating object, because you have you've kept it object 3 or 2, maybe you have made a choice, the child unable to locate. The problem for a child because of the occipital lobe may be problem. The temporal lobe contains the primary auditory cortex, where the vernix area. So auditory aspect of memory and learning is the most important area where amygdala, hippocampus, and the area where emotions are there, where we'll see the next diencephalon. It coordinates motor function and play a role in consciousness. The child is supposed to be alert, right? It regulates eating and thirst, because the child, most of the time, the parents only feeding the child. You want water, because the child never answer. They made a time. This is a water time. This is a eating time. This is a toilet time, because we have made everything systematically. Not training the child. We are feeding the child. We are giving the child, and control the body temperature and the cardiac rhythm. Hippocampus, which is mainly concerned for memory of immediate past, and then establish information in long-term memory and role in activating that information as needed. It is taking that, and it is concerned for working memory also, where I need to when the teacher is asking the question, the child is supposed to answer immediately. That's called is a working current active working memory. Then amygdala, it is emotional and behavioral function, where it's fear, anger, sadness, and also controlling aggression. But when there is most of the researchers show that amygdala is a area which is affected by children with ASD. So amygdala supports to store memories of events and emotions, so that a person may be capable to understand similar events in the future, because we have to train the child brain through the activities. That's what the child learned to reciprocate that activity, which whatever he learned day after tomorrow or next month or year, he will respond appropriately. And midbrain, which is contained nerve impulses between motor areas of the cerebral cortex to the spinal cord, and the reflexes where head, eye, and tongue responses, visual stimuli, and impulses, auditory stimulation, and the reflexes. And pons, which is signal for voluntary movements, equilibrium and information from the inner ear, because the inner ear has not only hearing, it is also have the equilibrium reaction, where I supposed to balance when the bus is turning right side, I supposed to balance left side. If it's turned in a right or left side, I supposed to balance in my right side. So like that, and it's control breathing also. The medulla oblongata, where the key body vital function, reflexes of swallowing, sneezing, vomiting, hiccuping, and coughing, these are the function which is regulated by the brain. Why we need to see the brain and function? Because it's associated. There is a problem in children with autism: executive function, motor performance, reproduction of language. Then the problem solving ability and spontaneity, memory, language, initiation, judgment, impulse control, and social, spatial orientation, everything is needed. That's what we need to see the brain and learning. Then we do assessment, which I told already, assessment tools. When the assessment is the first step in the intervention process. Everyone knows that. So the unique intervention needs of a child with individual with ASD to be assessed, and the educational team such as a special education teacher, or he is a process coordinator for a child with autistic spectrum disorder. The component of areas assessment which we need to assess: cognitive, academic functioning, adaptive functioning, social, emotional, behavioral functioning, communication, comprehensive, medical examination, sensory and motor functioning, and the family function. Most importantly, family function also to be assessed. The cognitive and academic area, which is current developmental cognitive level, whether the child is mild level of affected, moderate or severe or profound level of cognitive level lesion he has, impairment he has. Academic and pre-academics, where the academic, it's needed pre-academic skills, where he's supposed to, where the child is, can he capable of doing basic academics, which is pre-academic skills, pre-reading, pre-mathematical skills, or function academics, where the child will be doing with purchase, with the object money, with he is going there and reading the functional word and danger or safe or whatever the need. It is functional academics or academics. The child definitely can shine out through the academic skills, where first standard to fifth standard, maybe it is a regular classroom, inclusive classroom, or maybe in a NIEPMD classroom. Adaptive functioning, it's a day-to-day function. And social emotional skills, which stereotypic preoccupation with the child is always have a symptomatic, and experiences of victimization. Sometimes the child do some activity, he is victimized, he did it everything because of his inability. Why you are taking it? Most of the parents, they suffer a lot in getting the accommodation, the rented house, because of the child shouting sometime, yelling sometime, screaming sometime, banging the door, throwing object. They are victimized because of the behavioral functioning, the emotional social behavior they have. It is so formal. So hitting the behavior, they are biting self, they are hitting, they are doing others, and also self challenging behaviors. And the most important challenging behaviors with others and with self. And communication, it is needed speech language domains, which is including functional communication and pragmatic use of language. I'm asking something, I can show a tumbler because I may need water, I may need any drinks. So the pragmatic use of language. Then sensory and motor function, because we are doing it sensory, it's everything, it's a near sense, far sense, which we have that the near senses are your touch, tactile, smell, olfactory, gustatory, everything. The near senses are the far sense, which vision, hearing, that related to. Everything need to be assessed as a teacher. Whatever we are doing in the classroom, the based on IEP, that's most important. Then family functioning, we need to care the level of parenting stress, how they are making the child independent, what is the stress level they have, are they helping the child, are they training the child, are they supporting the child, or whenever we are giving the homework, are they practicing it, the homework related to not writing, the skills which you want to enhance related to your psychoeducational profile, or maybe curriculum, or maybe the adult psychoeducational profile, or maybe the developmental assessment, how they are doing it. Impact on siblings, how the siblings are helping or involving the child training. The extent of family support network, resources should be assessed, because some of the program, because the child is not able to sit in a commode, the regular Indian commode, you are suggesting that he need to be sit in Western based toilet, and he's supposed to give a shower pass. We are suffering a lot for a daily bread, and how you are expecting the parents to do a health faucet or commode changing. That is not my house where I am turned into a rented house. So you have to see the resources, access, and of the interest. So you have to develop your intervention plan, set your goals through the IEP. We know that special educators and the professionals related to special education, we know IEP, individualized education program, in each area of component, which I said that children with autism spectrum concern, and IFSP, individual family support plan or program, which is related to mother, father, grandparents, siblings, and the involvement of family is supposed to do in the home environment, helping the child all the areas of concern. And where you have to start the training, the child, young children, what you need to do it. Functional communication remains one of the strongest predictors of adaptive outcome for individuals with autism spectrum disorder across a lifespan. So the communication remains one of the strongest predictors, because he is unable to communicate, because communication needed for adaptive functioning also. So what you need to do in young children and other individuals with cognitive impairment, a principal focus of intervention often is the development of communicative intent. I need something. You have to cry, or you have to pull me, or you have to show me, or you have to point, or you have to show some written card there available, or you have to show your some sign, gesture communication to get something. For if a child feeded properly, he'll be active enough in the class. If he is not fed properly, he will not engage in any activity, or special education, physiotherapy, speech therapy, occupational therapy, whatever the therapy he need to focus, he never. So communicative intent and functional communication is needed, and through the form of verbal language, sign language, or argumentative alternative communication. If a child is school-aged children, what is our focus supposed to be? Acquired, reasonable. There also the communication most importantly needed. Attention typically tends to then progress is the academic and social skills. You progress with the academic skills, where the child, which is I told you, basic academic, functional academic, academics, where the child is there, and his level and his ability to learn in the classroom. Then if the child in transition level 14 years above, he is an adolescent, he is 15, or he is in a pre-vocational or vocational level, the transition supposed to be young adulthood critically involves identity formation, because who I am, he is supposed to prove some activity through the skills which we are going to do, become value contributing members of the society, because we have to make the child. That's what I told you, that he may be a plumber, he may be a mechanic, he may be a cycle repair shop person, he may be a painter, he may be an artist, he may be a drawing personality, or maybe art and craft, he may be a dancer, he may be a activity related to personally he is good enough in hand function, and his ability to show that I am a production or contributing member to the society, because people with the disability also contributing members to the society as per the law, RPWD Act or National Trust Act or UNCRPD Act. The objectives goals, we should focus on language, communication, play skills, social skills, behavioral flexibility, vocational or other services, transition, medical skills, because these are the evidence-based practices which is already said by people. Prompting, reinforcement, the topmost is starting prompting, which we are doing at prompting, visual, physical prompt, verbal prompt, gestural prompt, cues, reward techniques, which is reinforcement, video modeling, natural text intervention, social skill, visual support, behavior, parent implemented intervention, because parents are most important person, cognitive behavior intervention, antecedent based intervention, AAC, peer based intervention, and they have found these are the evidence based practices in the classroom. Effective intervention, we can see antecedent package, which is related to ABA, prompting, behavioral packages, these are the behavioral packages, and behavioral package, the modeling, video modeling, and etc. And behavioral package, self-management and social skill developing. There's intervention which is selected intervention in the classroom, where you see that most of the intervention which is seen, social skills improvement, the intervention and the use, social, communication, behavior, academic are the teach approach which starts from birth to 18 years. They can use the communication, social, development, cognitive, all the areas they can use it. And prompting 2 to 22 years, which we can use it all, because we know that prompting, how we are using it every age group. And stimulus control, the environmental modification, where the child with autism spectrum behavior, the consequence, because we stop the environment, the antecedent, the behavior will not occur, because that is the most important thing. Stimulation, time delay, whatever we are making the prompt or given the 6 to 11 years, differential reward, where we are making a differential reward for low rate behavior, differential behavior, the reinforcement for alternative behavior, differential reinforcement for other behavior or incompatible behavior, like that we are making a differential reinforcement, increasing the child activities, where 4 to 12 years, all the skills which is the right side, you can see that. Reinforcement, positive, negative, and discrete training, functional behavior assessment and analysis, where ABC, the function of the behavior, whether the child is behaving like this because escape or skill deficit, or he need something he want to ask, or it is a sensory because of my hand flapping, body rocking, it's a sensory, or he unable to communicate that he want to go to toilet, he is pushing down trouser down, because he is showing it is not a behavior of pushing naked. No, he want to go to toilet. Maybe he is expressing his need indifferently. So you have to be very careful about antecedent behavior consequence, where functional behavior analysis and its concern, the function of the behavior need to be analyzed. And communication training and extinction, where the reward can be removed temporarily, because time withholding the reward. Sometimes it starts from that academic, communication, interpersonal, motor, personal skills. Task analysis, where we are slicing the steps of individual skill to train the child in his independences. Joint attention, most importantly, it's needed for social communication and communication. Modern environment, where he play, he encourage a conversation, providing choice, direct, natural, pushing, pulling, because we forget everything, because we see that the joint family made everything, because grandmother used to tell stories, grandfather used to hug the child, kiss the child. What did you do? Where are you, Kanna? What is this? Oh, you learned this. So they express their feelings. And father, mother, hey, don't do that. Mother will be telling that, ask nanny to tell, ask grandmother to tell stories. She will be singing very nicely. Go and ask her. There was an unlimited, unbounded communication was there, but nowadays it is we are broken, and it is the segregation of families made everything different. So the environment, naturalistic environment, makes focused stimulation, incidental teaching, milieu teaching, embedded teaching, and it makes the child pre-linguistic. So it starts from the early age to 9 years in the classroom. Parent implemented intervention. Parent are the most important stakeholders of the children with ASD. So peer mediation also is needed. One of the weakest component in the regular classroom, the peer mediated cooperative learning. It is a cooperative learning, cooperative teaching, and incidental teaching also it's happened. The picture exchange communication system, social skills intervention, structured workstation, what the teacher every day we are doing it, the structured workstation where individual education plan which start, finish with the activity. Computer aided program, which is we knows that we know all the age group we are using it. Visual support, most of the children with autism, they are visual support. That's what we have to present visual matter. Even we are also visual learner only, because we see Vijay movie or Amitabh Bachchan movie. We used to see that instead of listening a story, we see picture which is enhanced with the motion pictures. We love to see that. Some of the advertisement we see, it is very interesting because the movement, the color, the picturization, that moving picture, the fast, that color coordination and synthesis, it's like gives me immense pleasure to see that movie. That's what we also need to provide visual support for children with autism spectrum disorder. Maybe a child who is a tactile learner, maybe a child who is an auditory learner, maybe somebody who is a kinesthetic. So we have to see the support what the child is needed. Based on that, we have to provide. The outcome of the study, they have reported communication is communication, social skills, challenging behavior is the most important, frequently reported from the studies which is done. And the second level, academic and pre-academic skills, play, school readiness, adaptive and self-help skills. And third, also most importantly, they have provided, because adolescent stage they made it, academic, pre-academic skills, vocational skills, and their mental health. There are yes. Hari. Hari.
Yeah, you continue.
The implementer of the program is educators, teachers, early interventionists, and parents, peers, siblings. Related services are therapists, psychologists, SLPs, PT, psychiatrists. These are the interventions which dealt by educators, parents, and related service providers. So the classroom management, we do traditional strategies, creating rules, preparing lesson plans, establishing routines, establishing classroom procedures, and non-traditional strategies using visual supports, providing schedules, collaborating with many adults in a single day, implementing behavioral support plans. So through the instructional planning, as a special educator, we do assess the skills and needs, plan instruction, implement instructional plan, and the UDL method, which is multiple means of representation, multiple means of engagement, multiple means of expression, where making the child to learn. Collect the progress data, where you have to do a summative continuous assessment for the child learning. And if he achieved, go for a plan, new skills. If he not achieved, see that why a planning was not happened. What is the problem? Maybe as a teacher, I may be the problem. I couldn't present my teaching learning materials properly, and was not suitable for the child, or maybe the child is really not capable of learning that particular, maybe basic academic, and functional academics. So you have to see student, most importantly the student, the input which you are giving, most important is the input how you will be giving, that will impact the child learning. The process, how you are making the teaching learning materials, or your learning activity, the procedure, the system you are making it, the product definitely will come as a return of the child achievements. Determine progress through continuous review of your teaching, monitor student progress through IEP, IFSP. Thanks a lot for attending this program. This is a summary, and this is a schedule of activity which we can do it already we are doing it. This is my classroom activity weekly schedule, and this is an individual schedule, and this is the daily routines which we have a pictures and visual schedules, prompt card, and task reminder. And finally, I want to show the only one picture. This is my children are prayer, and this is me where I am having the apron, where you see that only chefs are having the apron while they are cooking. As a teacher, previously you see that doctors will go with a stethoscope and a suitcase with the injection tablet and ready-made tablet which is available. Nowadays it's made because the COVID is made that doctors go with a stethoscope and a temperature meter and the tablet is supposed to be given immediately for prevention basis. As a teacher, we need to keep up. There are three lobes will be there. One is in yes, no, immediately if the child is doing a behavior, I have to show yes, you are right. If the child misbehaves, I have to show no, you should not. Then I have an activity card in the right side of my house where if I am doing a activity related to color concept, number concept, or whatever it may be, I should have keep material ready when I am addressing the activity. If the child is ready, the teacher is not ready, getting the material, pulling the material, going there and coming there, automatically the child will be disturbed. He will be having a we are the person to create behavior problem in the child learning skills. So try to create yourself as a creative teacher, a talented teacher, an appropriate teacher with addressing the needs of child with autism spectrum disorder on behalf of he is supposed to be independent in his all the age in the life endeavors. Thanks a lot for patient listening.
Thank you, sir.
Thank you, ma'am.
Moving on to fourth part of program, I request Sri Harimati, Senior Level Clinical Supervisor in Department of Speech, Hearing and Communication, NIEPMD, to give vote of thanks. Hari,
Yeah.
over to you.
Yeah, thank you, ma'am. Good evening to all. On behalf of National Institute for Empowerment of Persons with Multiple Disability, from the Department of Speech, Hearing and Communication, I take this opportunity to deliver the vote of thanks to those who have directly and indirectly contributed to this international episode of ASD, Autism Spectrum Disorder, Series 2. I thank Sri Nachiketa Rao, the Officiating Director, NIEPMD. Thank you so much, sir, for your motivation and concern and guidance. I thank Dr. Amarnath, sir, HOD, in charge HOD, Department of Speech and Hearing. Thank you, sir. Thank you for your support and encouragement, sir. And our thanks, international speaker, Dr. Swapna Bhatt. Thank you, ma'am, for your dedication and your precious time. It was a fabulous presentation again. Thank you so much, ma'am. And thank Mr. Dhananandan, sir, from NIEPMD. Thank you, sir. It was a fantastic presentation from you. And thank you. And thank to Dr. Kala, ma'am, from NIEPMD. Thank you so much, ma'am, for the constant effort and great presentation. My special thanks to my beloved organization team, Ms. Gayatri and Srimati and Mr. Sanjay from Department of Speech, Hearing and Communication. Our heartfelt thanks to the professionals and students from various parts of India. Thank you. Thanks for listening to this episode. Thank you all. Thank you, everyone.
Thank you, Hari.
Thank you, Hari sir.
Yeah. Shortly, I'll send the e-certificate link and it will share through the WhatsApp and chat box also. Please fill the form. We'll have a small quiz program and you'll get the e-certificate. Okay.
Thank you so much, Hari sir.
Yeah, thank you. Thank you.
Good evening, sir. Dhananandan, sir.
Good evening.
Sir, thank you, sir. This is Prashant from Andhra, sir.
Thank you, Prasant. Thank you, Prasant.
Okay, sir.
Thank you.
Nice presentation, sir.
No, thanks a lot, ma. Thanks a lot.
Okay, sir.
Please post your question if it is there. Anything, we'll let you know that. Thank you.
Okay, sir.
Thank you, Prasant. Thank you, Prasant. Hari, if there is no question, we can officially sign out, Leah.
Yeah, yes, sir. You can, sir. You can.
Just discuss with madam and you can make it.
Yeah, yes, sir. I'll send the e-certificate link for everyone through WhatsApp and chat box also.
Okay, we'll wait.
Then now it will wind up,
Okay,
sir.
we'll wait. Okay, we'll wait.